All right. Can I confirm that the
Yeah,
screen is visible?
yes, we are viewing your screen. It's very
All right.
busy.
Thank you so much once again, Mr. Samson. Thank you so much, Busoga Health Forum, for this opportunity. We really don't take it for granted. The initiative you brought on board, discussing every Friday matters that concern health, matters to better patient, care, is really a great pleasure. And we are much honored to be on this platform tonight to discuss one of the most commonly performed procedures, which is cesarean section. Uh, all of you who are on call tonight, we really appreciate. We don't take this for granted. That's a sign of passion for what we do, a sign of passion, to better our practice as far as patient care is concerned. So we want to keep cesarean delivery rates at every, health facility in check. And how to do that is by use of the Robson classification. The outline for tonight's discussion is quite simple. Uh, just understanding the need for us, to keep the civilian delivery rates in check. And then as well understanding how we can use the Robson classification as a tool to audit, monitor and compare civilian delivery rates uh, within our health facilities over time and in between them. So to start with, you could be wondering what's the essence or what's the purpose of tonight's discussion, and why would we be interested in, analyzing cesarean delivery rates? I must tell you that cesarean section rates are on a rise globally, and this has brought on board a number of debates whether its increase is actually beneficial or is, disadvantageous. If you look closely, the recent studies actually reflect that cesarean section rates stand at 21.1%, with a projection of increasing up to 30% globally. So what does that mean? It's a progressive increase. And when you focus locally in our country, Uganda, the Pearl of Africa, you actually realize that the same trend is occurring. A study was done and reflected that actually our cesarean delivery rates are about to double by 2030. I mean, the question still remains, if they double, are they offering a benefit or not? You will understand that actually, if a cesarean delivery is done on a medically justifiable ground, it actually offers a benefit. It has been proven in various studies that medically justifiable cesarean deliveries actually reduce morbidity and mortality, both in the mother as well as their newborns. However, we need to also appreciate that the unnecessary use of cesarean section actually offers no benefit. Instead, it just risks the mother and their newborn different complications. They can be immediate things of hemorrhage and so on. There can be the long-term side effects, including those that will affect subsequent pregnancies. So in us auditing and, trying to monitor and compare cesarean delivery rates, it has actually been difficult, to tag a particular cesarean section rate as optimum for all facilities. The reason is simple. all facilities are not the same. Some facilities are having better infrastructures. All these facilities, some have even gone ahead to have their individual, guidelines. The obstetric population alone served by the different health facilities is very different. A regional referral hospital will not serve the same obstetric population as a health center for. So, I mean, that's why we can't say maybe 15% is the optimum for all facilities. And that's when the WHO comes in and says all effort should be made to provide cesarean section to mothers in need, rather than actually striving to achieve a specific rate. So that gives us the need to actually understand the cesarean delivery rates per facility. Keeping in mind that actually the 10 and 15% cesarean rates that are given as references, they are actually population-based, cesarean section rates, not healthy facility-based. So what's the tool to use in this purpose? WHO in the year 2015 actually launched the Robson classification as a global tool to be used in the purpose of assessing, monitoring, and comparing cesarean section rates. These can be used within a facility over time, like we can say every month, maybe every year, we compare our cesarean section rates, we monitor and audit, but as well, we can compare the cesarean section rates between the different facilities. And perhaps this can better practices by informing, say, group-specific interventions. If we are to compare facilities that actually have similar infrastructure, similar protocols, but as well as having a similar obstetric population served. So what's the Robson classification now? This in the literature, different scholars have given it different names, and but importantly to note, it can also be called the 10-group classification system, simply because it classifies all mothers delivering from a specific facility into, one of the 10 groups, as we are going to see. So this classification is based on the variables we actually collect on a daily basis. These are the 6 core obstetric variables, as we are going to see. Importantly to note also is that it's actually simple. We've used it in our study, the recently ended study at Guru Regional Referral Hospital. And I mean, we have results. It has informed points of change in practice. So it's simple, it's a robust tool, that is actually also clinically relevant. At the end of the day, after using the tool, we shall have action points other than just, the formal, or the traditional way we've been just looking at the overall cesarean section rates. So what are the 6 obstetric variables? We have parity, and parity can be classified as nulparous or multiparous. When you read the Robson classification implementation manual, it describes everything in detail, and it emphasizes that a parameter that, if, for instance, say parity, if a particular facility has a different definition for parity, it can also be adopted and used instead of the standard one that is used in the Robson classification. Parity in the Robson classification is the number of fetus that have been delivered say greater or equal to 500 grams or gestation age of 22 weeks. But here 22 weeks the fetus can't survive, so we go by 26 in the latest guidelines. So you can still use the definition of parity to classify your mothers. The other is previous scar. Does the mother has any previous cesarean section or not? That's self-explanatory. Looking at the onset of labor, when this mother came in to deliver, was there labor? I mean, was she in labor? And how do we define labor? So different definitions will be adopted by different facilities, but still the standard or the recommended by WHO can be thought from the Robson classification manual. It can be spontaneous labor. Actually, mother can also come in and is not in labor, but we induce labor. Or some mothers actually come in and they are not in labor. We do a pre-labor cesarean, cesarean section. Perhaps maybe we are afraid of the complication, things like maybe uterine rupture. So you immediately act and offer a pre-labor cesarean delivery. The other one is number of fetus. Is it a single pregnancy or a multiple pregnancy? A gestation age term has been classified as equal or above 37 weeks of gestation, and then preterm as below 37 weeks. Then lastly, having the fetal line as cephalic, transverse, stroke oblique, and then breech presentation. So I believe every one of us who has worked in a maternity unit and is on this call agrees with me that these are the variables that we actually collect on a daily basis. So this makes our work easy, that if we have all these parameters for mother, we can classify this mother. Moreover, at the time of entry into the facility, not after the mother has even delivered, because the final mode of delivery does not matter and is not part of the classification system. So looking at the 10 groups now, I would love to take us through how to classify, but at the same time as we appreciate how the groups are composed. So we have, we start with all multiple pregnancies, and these all belong to group 8. All of them, irrespective of the gestation age, irrespective of the fetal eye, and all other parameters. If not multiple pregnancy, then it means it's a single pregnancy or singleton. So the other question is that baby in oblique or transverse line? If yes, that's group 9, all of them. Then if not oblique or transverse, is the baby in breech? If yes, the other question is this a mouthpass mother who has delivered before? And if yes, then that mother is classified to belong to group 7. If the mother is having a single breech presentation but is now paras, then she belongs to group 6. If she's not having a breech presentation, she's having a singleton pregnancy. The other question still we ask about actually this is meant to be a gestation age. If she's a premature, then or a preterm, then she belongs to what? To group 10. Sorry about this error here. About group 10. It's about gestation age. All mothers who come in, with a preterm delivery or a preterm pregnancy, for that matter, belongs to group 10 as long as they are a single pregnancies. Then we continue and ask ourselves, okay, she's not a single, she's not having, she's not a nulliparous, she's a multiparous. Does she have any previous scar? If yes, then all of these belong to group 5. But importantly to note that in group 5, as we well know that a mother can have one or more previous scars. So meaning group 5 can actually be subdivided into those having only one previous scar and then those having more than one previous scar, because that's crucial in determining whether you're going to offer VBAC or not. Then if not a previous scar, was this mother induced or she had a pre-labor cesarean delivery? If she was induced or had a pre-labor cesarean delivery, then she belongs to group 4. If not, meaning she was in spontaneous labor, then that's group 3. Yes. So if this mother is still not a multiparous, she's a nulliparous, then the question is, was she induced or had pre-labor cesarean delivery? If yes, that's group 2. And if she had spontaneous labor, she belongs to group 1. So that's all those are the 10 Robson classification groups into which these mothers can be classified. And after this simple exercise, you critically analyze and understand which group contributes the highest, which one contributes the least to the overall cesarean delivery rate. And then you compare those different groups and come up with, a strategy to optimize the use of cesarean delivery. So this is how we report the findings. This is an extract from our research recently done. We did the survey in the study period of 2019 to 2020. That's a one financial year. So you realize that the table is actually a 7-column table, having the group, number of cesarean deliveries, number of mothers, size of the group, looking at the group cesarean delivery rate, looking at the absolute contribution of each group to the overall, and then the relative. Yes, so if we are to just try to look closely on this table, you realize that actually in our study, the groups 1 and 3 comprise the biggest proportion of the obstetric population. These are low-risk groups. Group 1 are those nulliparous, at term, cephalic presentation, spontaneous labor. Then the question is like, why would they be among the leading contributors to the overall cesarean delivery rates, as you can see from the table, having 27.1%. Group 3 likewise is also a relatively low risk group. The question comes, why is it among still the leading contributors to the overall cesarean delivery rates? That's how you start to tease out and come up with a strategy or evidence-based intervention to optimize the use of cesarean delivery at your facility. So how do we interpret the data in the table? I already gave a hint. At least you see how to tease it out. Now, it's simple. Start by assessing the quality of the data you have. Is the data complete? Do you have some mothers that have not been classified or not? Are there some misclassifications because they are really common? They are common. So you need to critically look at your data, review your data to ensure that you have high quality data. Because if you have wrong data, you come up with a long conclusion and you're not going to offer benefit to our mothers. So assess the obstetric population you have. You've seen in our study that actually the highest percentage, over half, actually more than 3/4 almost, was, low risk population. So assess the population and understand, say, how many mothers came in to deliver and they had previous scar, because at least, in our settings here, we even fear risking a VBAC. We think every mother with a previous scar is automatically, another cesarean delivery. So understand the obstetric population. Then lastly, as the point of focus, assess the cesarean delivery rates per group. Look at the group, what does it contribute to the overall? And then compare those different groups. Try to, think around and understand what could have led to those high cesarean delivery rates in a particular group, and why some groups have even much lower cesarean delivery rates. Still, this is an example from our study assessing the quality of data. You actually see that there were gaps as far as data collection, documentation, and record keeping is concerned at Guru Regional Referral Hospital. These were over 5% of mothers that delivered during that study period were not able to classify them simply because they had missing variables. And you can see from the pie chart that it was actually presentation mostly missing, having missed 22.6% timers. So appraise your data, assess the population you have, and again, assess the cesarean delivery rates in different groups. So I believe every one of us on call is wondering who needs this data. So if we do so and compare everything, who need it, who use it? I mean, even you yourself was compiled it. You need that data because you need to draw conclusion from it. Researchers, policymakers, clinicians, administrators, I'm happy to learn that we have even non-health workers on call, because actually our bosses are not health workers. So if we don't involve them in such discussions, then we shall not convince them when it comes to policy making decisions. They are going to overtake us, and they will not believe what we've come up with. But if we have this information, evidence-based strategies can be developed in conjunction with everyone. Of course, the mothers inclusive. Some are requesting cesarean deliveries, not knowing the consequences. So if we inform them, they can actually change their mind, perhaps to opt to try a vaginal delivery. Well, no one is perfect, and I believe we can't have a perfect tool. Different tools were developed, but still, of all of them, Robson classification met the criteria for local and international demands, but it has a few setbacks. However, these can be adjusted for, and we can have quality data and draw patent conclusion from its use. So some of the setbacks are missing data or variables, like you've seen, that will have to make you have a group of unclassified mothers. What if those unclassified, they were all done cesarean section? then your overall cesarean delivery rate is wrong. You're going to draw wrong conclusions. Misclassifications. If you don't analyze your data, look at your data critically, you're going to misclassify mothers. You're going to come up with long, conclusions. The other is the discrepancy in the definitions of some of the core variables. Hospitals like Lacho have their own, even prescription guideline. So if they also have different definitions of the 6 core variables, it makes it a little, again, difficult to compare with, say, good regional referral hospitals, which follows the overall Ministry of Health, guidelines. But still, facilities that are having similar guidelines can offer us an opportunity of comparing their cesarean delivery rates. As I come to the conclusion, I must remind all of us that if you are to leave this discussion tonight, remember that addressing cesarean delivery issues is actually the priority of the 21st century. And to address this, we can only monitor, audit, compare these rates between facilities and within them over time, using the Robson classification tool that has been recommended actually by the WHO. And if we are to use this Robson classification tool meaningfully, we need to create databases routinely. Here we can actually develop a database that collects all those 6, core variables collectively. One of our challenges in our study was that we reviewed the maternity registers, and in maternity registers, some of those parameters were not properly outlined. So retrieving such data in a retrospective way was a little challenging. However, if we design a database to collect it, say, monthly, weekly, reviewing it on an interval basis, then we shall come up with a good, bunch of data that can inform policy change. So lastly, you need to understand that in us addressing cesarean delivery rates, we need to inform our group-specific interventions. The campaign here, I must let all of us understand that is actually not, it's not to stop, or it's not against all cesarean delivery rates in total, all cesarean delivery in total. But this campaign should be targeted to address the unmet, the unnecessary, and the unsafe cesarean deliveries. And that's how we're going to optimize the use of cesarean delivery. Thank you so much, everyone. I come to the conclusion of my presentation, and I'll welcome any submissions, any questions. Thank you so much.
Thank you, Doctor, for the presentation. And as I had already guided, the questions shall come at once after the second presenter for saving time. Let us straight away have our second presenter. Then after him, we shall get the questions and answer them. Thank you. The second presenter, Dr. Pebalo.
Yes, thank you. Thank you so much, Samson. Can I get a right to share the screen? Because I think the host has not allowed me to.
Elizabeth, please, you can make Dr. Pebalo. Yeah, you have already made him co-host. Okay, thank you.
Are you able to see my screen?
Yes, we can see the screen.
Thank you so much, Eric, for this.
Yes, try to be clear your network, like we are not hearing the words. Your
Thank
audience.
you. I want to applaud Dr. Eric Ssennuni for this elaborate presentation on Cesarean section. I just had something few, and then after that we'll actually be ready to answer questions, and then some additions from senior members, and then all of us should be able to contribute so that we walk out of this when we're happy. I want to just share something special. In 1870s, I want to remind all of us that Cesarean section was being practiced in Uganda already. And this is a picture that was drawn by one of the explorers that came then, before he was actually a medical student who came to Uganda and published. And this was actually done in Western Uganda. So I think this is something that we should be proud of, much as in the history of Cesarean section, we say we read stories around maybe Julius Caesar being born by Cesarean section, which is not so clear. But I think Africans were already practicing this, and this was actually some paper that is published, a record of what Robert Felkin found between 1857 and 1926. So he wrote something around 1879 about Cesarean section that was done in Western Uganda. It's an interesting read, and when the moment I want to talk about Cesarean section, I want to refer to this because it makes me proud of my country. This is just what Dr. Eric has talked about. He realized the world over Cesarean section rate is increasing, and the increase is expected to actually hit around 30% by the year 2030, and that's not so far. We are only about maybe 7 years from that, to reach a rate of 30%. But in some part of the world, Cesarean section rate is so high. If you look at Cesarean section rates in Brazil, it's too much that probably they need to do something about that. A rate of where you can actually, for every 3 mothers, 2 of them get Cesarean section is a bit unusual. And probably because of, if you see practices, even within our country here, practice around private hospital, private clinics and whatnot, Cesarean section rates are quite high around this area. Although we don't get rates, we don't actually get a clear report about that. But because people fear litigation, people fear maybe monitoring labor over a period of time, people don't get a lot of midwives getting involved into labor care. So this makes it a bit a kind of practice. And of course, the difference between the monitoring labor until delivery, that may take at least maybe 12 hours, and then doing Cesarean section. Some people do Cesarean section in 30 minutes. You do Cesarean section and you pay slightly higher, and then you monitor labor, you're paid low. So there are a lot of things that happen. And then there are some indications that are not verified at all. When you have a mother and you tell the mother that probably there is non-reassuring fetal heart. I mean, there's no standard probably for non-reassuring fetal heart that we need to follow. Although there are guidelines for this, but not all of us are using these guidelines. It's just about you deciding and then making that some indication, like probably prolonged labor. WHO tried to discourage this kind of thing. If the mother is okay, the baby is okay, a prolonged labor, you need to find out the primary cause. And then also practice around avoiding the alternative of deliveries. We have seen in many practices, people avoid other alternative methods of assisting birth, maybe assisted vaginal birth. In the Netherlands, they actually have the highest assisted vaginal birth, but they have the lowest cesarean section rates. But in our setting here, we realize most practitioners prefer to avoid using vacuum-assisted deliveries, probably citing the complication that occurs. But looking at the complication that occurs on the baby only, but how about the cesarean section that occurs? How many mothers have died on table? How many mothers have gotten infection after cesarean section? How many mothers have gotten maybe eye spine or something like that? So we need to look at all this before we could actually think about. This is just a world map that shows how this cesarean section rate is distributed. And you see Uganda is somewhere down there. The rate is actually between 5 to 10, 9.9% of all the population deliveries. And you see in Brazil and then probably China, the rate is quite high. This is a paper that was published in BMJ comparing rates between 2012 and 2016. So you realize that there are changes in the districts of Uganda, even there are changes in the rates that are clearly coming up now. So with the time, because of maybe good obstetric practice, maybe changing obstetric population, the rates in Uganda, as has been predicted, will actually double by 2030. I want to borrow this slide from our neighbor in Kenya. In this paper, they were discussing about how cesarean section is contributing to maybe the cost of living, the cost of healthcare in Kenya. And of course, they went deep a bit, look at world over, and realized that almost 6.2 million cesarean sections are actually done, and this the indications are really unnecessary. So that's a global picture. If every year we do 6.2 million cesarean sections, that has no clear indication or unnecessary indication. That means that we're actually risking our mothers a lot. And then, of course, it said here that Brazil, 2 in 3 cesarean sections, Brazil is having a problem. And a lot of money is spent in cesarean section. If you look at these 140,000 Kenyan shillings to 280,000 Kenyan shillings, that is almost like 5 million Ugandan shillings, around those shillings. That's the average. That means that if you move to Kenya, if you're Ugandan move to Kenya, you will actually pay maybe 5 times the cesarean section rates that, cost that you need to. So it is estimated also that worldwide, cesarean section rate is actually increasing at the rate of 4% every year. So you just know that we are doing that bad. I want to also use this conceptual map to a bit dissect into what we can see, and this is where intervention can be put to actually correct, especially group-specific intervention that is generated from the Robson classification. Realize that there is unsafe cesarean section, and then there's safe and respectful delivery. That can be a vaginal delivery or a cesarean section. This unsafe, unnecessary cesarean section can be because of a number of issues that can be generated. And this could be because of lack of practice for alternative. I really said earlier that a number of people do not buy the idea of vacuum-assisted delivery. Number of people don't even practice forceps delivery. Yes, I trained in Uganda, and I know I didn't get a chance of actually maybe forceps delivery, but I do vacuum-assisted delivery. One of that should be able to help us, and this can be because of preferences from from the mother, and this preference is actually amplified by peer pressures. Sometimes people actually tell mothers, why don't you do this? Why don't you do this? Why don't you do this? I have seen a number of couples who come and the man really prefers cesarean section, even if you actually scan and then maybe the risk is not so much, and they prefer cesarean section. There are also for the safe for the safe and respectful delivery, there are some few elements that we can actually use to help us make sure that we inform group-specific intervention. This could be because of the living and working conditions of the mother, or because of health system factors that are there. One of the things about living and working conditions of the mother is based on the social community and family networks that a mother has. If she's already employed, what kind of work is she doing? What kind of level of education does she have? Because this helps them to decide how much income do they have in the house. About the housing, where do they stay? You can't compare someone who comes from my village, maybe in Halabek, to someone who had been living in town here, because they know how to maneuver the system in the hospital and then probably have something done for them. It could also be because of funding and coverage. You realize, of course, at the moment, most of the things in the government setting is actually funded by the central government. But in private setting, what is the funding? People who have money can actually access cesarean section at their will. People who do not have money probably need to depend on the government system. That is sometimes even clogged. You realize if you practice in Mulago, you see what happened there. Sometimes you have an emergency list, a long emergency list. By then, when we were practicing, probably it has changed now. A long emergency list is not a good indication for system, but because all the centers there is no clear referral system in our setting here. People just walk from home to Mulago, a national referral hospital. People walk from home to Gulu, a regional referral hospital. Dr. Eric, if we had dived a little bit longer into the data, we'll actually show to you that more than 70% of the people who are obstetric population who came to Gulu Hospital were actually self-referral. They were not referred. So you can imagine someone walk from home into a referral hospital. Yet this referral hospital is supposed to receive people from the peripheral centers. The other thing that we can look at is the infrastructure. Dr. Eric dive into this and said, we cannot tag cesarean section rates for each facility, for all the facilities together, depending on the personnel that is there, because the personnel, the way they practice can be slightly different. The infrastructure that they have can be slightly different. You realize sometimes a small delay in the labor suite, because theater is actually occupied, results into some mothers delivering before. So this kind of arrangement, if you act fast, you could have actually done cesarean section, but because there was a delay somewhere, some of the mothers will actually push. And then also it depends on the quality of care, and quality of care is very important. And that's why the Robson classification will help us to look at group-specific cesarean section rates. And we can actually use this to do a better way of understanding this. Thank you so much, Samson. Back to you.
All right, thank you very much, Dr. Pebalo. Actually, you have